The two last session of this half day, I will introduce you to something a little bit outside the cranium and outside the spinal level, which is the external carotid and vertebral arteriovenous fistula, that we can embryologically call it parachordal. What is the similar in nature between these two locations? The embryonic center of this malformation is the nodal cord, which the nodal cord ends at the basic sphenoid level, at the junction of the somatic branchial and prebranchial somatic part, and rostral end of the nodal cord, sinus plexus, which arterial supply related with maxillary artery and extradural internal carotid artery. And caudally around the nodal cord is all the segmental arteries. So neural crest and mesoderm development of segmental vascularization. So we are talking about this area of the cranial-vertebral junction, which is for sure you have heard that as an inferential occipital costal cervical, including the first cervical segment of internal carotid artery, and in the somatic level, the vertebral itself, the segmental and intersegmental arteries will involve in this condition. So the relationship is close by each other between arteries and veins in terms of each segmental artery over that area, and the cause is probably the defect in the nodal cord and related structure, as well as the mesodermal dysplasia, especially we have example in NF, neurofibromatosis type, and then it could also relate to any developmental errors during the vasculogenesis and angiogenesis. So will actually rupture into the veins. So what could be seen in the cephalic versus somatic level? So we will show you all example of this starting from internal carotid artery itself, maxillary artery as an inferential occipital, and related veins could be the external jugular vein, internal jugular vein, posterior jugular veins. And in the somatic level, all the artery, the segmental artery, are related mostly to the vertebral venous plexus or the posterior jugular veins. This group of disease symptoms are still related mostly to the venous drainage. It could be to the low resistant or a little bit higher resistant. And only the neurological, the more neurological problem occur when you have the central pedal drainage, which could be seen as the cerebrospinal root or radicular veins in terms of the somatic levels. What we say minor symptoms mean it can be asymptomatic or just bruised or pulsatile mass or bruised hurt by the mother or the physician when they meet a young child. Not very often that the congestive heart failure can occur only in very, very young child. And most of the neurological deficit can occur mostly related to the compression by the venous ectasia. Not very often that we have pyovenous congestion related to the reflux. Don't forget that in the metabolic arteriovenous chart, we can still have this group of fistulas related. And as I told you, it's not very often to see the venous infarction or pyovenous reflux. They are very unique and geographic findings, which is for sure very, very dilated tortuous arteries and veins. That is large fistula, and we have hard time to figure out where is exactly the junction between giant and large artery and large veins. So there could be some narrowing segment, but it's not, most of the time it's not very easy. So we can start by seeing all example, start with the level of cervical internal carotid artery. So you know that all of the segmental artery have some risks related to the cranial nerve supply. So during your treatment, you should be able to avoid. Believe me, our candidate is in the internal carotid artery. This is 11 years old boy. He came just with the mild chemosis of his right eye, and the bruises by the physician around the neck, upper neck area. So we were seeing these large artery, and then we know that there's large veins in the very early phase. So you can imagine that the fistula should be around the area of these gigantic artery and veins. And what created the symptoms is that not only the junction that it opened into the jugular veins, but it also reflects back here into the dorsal cavernous and ophthalmic veins. So that brings to the symptoms of the chemosis exophthalmos. So one example that you don't need to have the fistula or shunt only at the cavernous sinus that can present with the cavernous sinus symptoms. So if you are being able to hook, for example, this is collateral injection. The benefit, the value of injecting the vertebral artery is that you have the very high flow sumping down into the carotid, and now you see better where is the exact fistula's location. Okay, so we were able to use embolic material, which by that time we were having a lot of detachable balloons. So we now know exactly where is the fistula, comparing this vertebral injection to the carotid injection, and we will accurately put the balloons and close up the fistula. Remember, you will see the major difference in caliber between the pre-fistula and the normal artery after the fistula. It could be a lot of difference before it remodeling in your follow-up study. We have only one old case that this can be presented with hemorrhage. And you see that the injection here, you know that immediately around this area there is a vein, so the fistula must be around there. How come you have this? Because of this, so-called pylovenous reflux into this kind of previous encephalic type of venous reflux, and you can have the hemorrhage related to this disease, and then they put the embolic material over there. This treatment was done. Now we come to the maxillary artery, which seems to be the most common artery that have this condition compared to all the rest of the artery. So one of the presenting symptoms is the parotid calcitousness in your cheek, and this is the possibility of the artery and venous drainage. The branch can be also seen, which is this is the transverse facial fistulas open into the external jugular veins, and the bruit was heard, and also the symptoms could be in young children, the cardiomyopathy, or even mild congestive heart failure. And the embolic material was put there, now no more fistulas, and the rest of normal artery was seen. Why in this case you still see that with the catheter over there, you see the veins, and now if the embolic material was already stopped at the fistula point, this is direct maxillary to jugular arteriovenous fistulas. In the modern world now, this is what we see now in my department, that we have the same symptoms related to this pulsatile mass. There are many more images. For example, is to see very nicely the signal board, pouches, and structure. and correlated well with the MRA. And yeah, you see that even they put the color Doppler to make sure that you have the fistulas over there. During the treatment, if you're still confused where is exactly the fistula, again, your machine will provide all the 3D rotation that you can try to think. And now with the DSA 3D bone fusion, you have easier to see that, oh, now you change the caliber from this artery. Luckily with some narrowing, and you have the vein just at that location, so the asterisk here pointed to the last point of the artery connected to the veins, and now you have much easier that only few coils, if you are very accurate, it localizes the junction between artery and veins, you will be able to put the few coils which you see there at exactly the junction over there, and you can treat the patient nicely. Embolic material can be any of your choice. I mean, in this case, we were seeing a young man with this type of dilated artery. You don't know exactly, but we know probably this is for sure the vein. So the arterial to venous junction is around the area. So if you were able to put tip of catheter probably around this area, and this is the glue injection that we use, because there are already some narrowing segment to help you to make sure that the glue is not flying. Same as other arteriovenous fistula, you have worked with your anesthetist, and for me, we do ask them to do the hypertensive period. Probably the children usually have something below 90 already, but I prefer something at the early 80s historic. And probably it's good that you fix your tip catheter. The wedge means that your tip catheter should attach to one wall of the artery. That means in your testing, your tip catheter is not floating. When you test with the dextrose, that means it's not wedged. And if it's wedged, you have very good opportunity to let the glue slowly stop at the first venous pouch and not flying over. So this is like everywhere in the arteriovenous fistula, you want to inject the glue. And for sure, the thrombus signal will be seen like that in the follow-up, and the disease is cured. Don't be shocked with the discrepancy between the artery pre and post fistulas area. And what can be used if you, this is when we worked in Vietnam with the team there. You see, they were keen in using this, balloon at the tip, and they put micro catheter through the guiding catheter to the area that they fixed that it's already the very first venous pouch. And this is another way to stop the flow if the artery is available for you to use this, and the glue injection is nice because you just stop the flow by using this type of material, and this is the result that they can put the embolic material nicely into the area of the fistulas. What else we can use in the treatment is probably another symptoms that the pulsated disease can create the structure, the nearby pain, including the ear and throat pain. So this is when we inject the maxillary artery, and the team was keen to put the ampulous vascular plug to go into that area and go over this there, and they were able to much slow down the flow, and finally they have the evidence that they can stop the flow. How about the next artery? We are talking about asamipharyngeal and occipital artery fistulas. Usually we see in a little bit grown-up child, And for sure, with this artery, you can have the symptoms related to lower cranial nerve. This is lateral injection. You remember it is pharyngo-occipital system, and enlarge the pharyngo-occipital open into the jugular veins, and I think can use this nicely to see the glue to fix distal artery, proximal veins. So this is what we call mushroom injection, which is ideal to inject fistula type of thing. So this is another acid-differential open up into the lobulate of venous structure and draining up a very massive or pyovenous reflux that is also correlated with the images there, and they were able to put, I think in this case, is detachable balloons again with that closing up all the fistulas. Nice case from Insuk there. He gave me this because it's example of the occipital artery, enlarged occipital vein, open up into the suboccipital veins and finally drain down. And so it's again the pulsatile mass improved by the method. And I'm super keen in putting nicely the Aquarius pack at the junction of the fistula point and having the curative result. Somatic levels, we need to talk about vertebral artery itself or segmental artery that can have this type of disease. We can have this paraspinal, which I think in the next session, Kara have a lot of example to show you, but this is the same group that we gather as a parachordal venous shunt that can create it with these symptoms in the young child, and also the congestive heart failure can be seen. The treatment is probably if you can fix this fistula type, you can treat the patient with a transarterial, in this case, a segmental artery here of the descending aorta that have the fistulas, and even we see the intraspinal veins, and then also congested back into the inferior vena cava. And if you were able to close up, it's when you are remnant here in the follow-up, it's one of the treatment that can be seen in this group of spine. What we expose more is the called the vertebral fistula. But let me show you another interesting case. We see this 15 years old man with progressive corticolysis. You see the myelopathy over there, and you see that there is the ventral dilated vessels coming off from the right side, which is for sure this is epidural artery. That if you inject the left vertebral and you see this, enlarged artery open up into the enlarged group of the veins that finally compress the spinal cord. And by that time, we were able to put probably two sessions, two catheters to fix with this fistula we use in VCA. We were able to stop the flow, not necessarily completely, not see anything, but if you have a very much stagnation and no other ways demonstrated, that means you are in good condition already and is going to further thrombose by the effectiveness of the cyanoacrylate. This is the follow-up. It looks really normal for the right birth, and the collapse of the dilated vascular pouch used to compress the spinal cord in the follow-up study. Some of the treatment cannot be done completely by transarterial and retrograde transvenous. Most coils plus other embolic material must be used in terms of treatment of this disease. When we talk about vertebral arteriovenous fistula, we can mix up with this group of spontaneous versus another group that we can see either related to trauma or this group of metabolic malformation. We can divide it mostly into upper group and lower group, or from C1, C2, C3 up to C4 is mostly seen in the pediatric and not related to the collagen vascular disease, while the lower group we see more in the older age group and can associate with the collagen vascular disease, for example, NF1. So if we can differentiate the two types, including the cause of the lesion, we can know what we are dealing with. And I told you that the upper vertebral or intersegmental artery fistula, the collateral that you must inject is the ascending pharyngeal and occipital artery. While in the lower group, you must inject the cervical artery, or the ascending and the deep cervical, you must do. I will show you why. So the pattern of venous drainage can be each type of this drawing was nicely illustrated in Pierre's book. So as I told you, most of the thing is the large venous plate compressed the cord and a nerve root. So there are some possibility that have intradural venous reflux. For example, in this example in Pierre's book, seeing that suprarenal hemorrhage was there, and the left vertebral injection showing immediately the veins at the C1 segment of the vertebral artery, and retrograde filling back into the intradural veins created this bad hemorrhage, which for sure by that time the use of embolic material to stop the fistulas at the location was done. We published this together with the team when we were seeing these dilated ophthalmic veins and something at the corner sinus of the same side, and we were not able to find something from the carotid injection. So this is the vertebral injection. And in lateral, you will see that immediately at the C1 portion, you're filling up this strange thing that turns out to be inferior petrocranial veins, finally drain back into the petrosal vein, corona sinus, and creating this major congestion and possibility of bad venous reflux in the brain. So you need to know that this rupture occurred at that location, and it's in the group of extracorneous fistula that presented with the corona sinus symptoms. Okay, so this is the case after we were able to figure out the fistula. We use it's up to you. You can use whatever embolic material you like, and then we were able to close up. Just being able to know that it's the shunt is located there. Angiographic protocol I told you for upper and lower group. So example of this child will have you this fistula at the C1 segment of the right side there. And ipsilateral vertebral have confusion where is exactly the fistula, right? The contralateral already shown that is there, but to make sure that you understand and make sure that the fistula is cured when you did embolization. After pre-embolization, you see the possibility of C1, C2, C3 collateral to fill the fistula. You need to go and hook also into all the collateral arteries. Make sure that not only in vertebral injection you can prove that you did good job, because if it's still there, you need to either go for the final embolization or wait, because if in case that it starts to be thrombosed, very, very slow flow, if you wait 5 or 10 minutes, you may have the result of closing up the fistulas. We were seeing this at a little bit lower, and the symptom is now with the impaired sensation of the tongue. That you know that the nerve lying at the level of that, and it is seen that again vertebral injection showing you this ipsilateral and contralateral vertebral study. We were able to close up the fistula in this case. There is no contribution from the ascending pharyngeal and occipital, so we didn't show you. So this is a follow-up which is usually enough for the thing, and we were able to close up the fistula. So in terms of treatment decision, we hope the complete eradication. Not only the ligation of feeders, some feeders. So endovascular embolic matter can be any, and sadly the chance of preservation of the vertebral artery is much less than in other fistula. For example, we do a lot of traumatic CC fistula, we were able to preserve the artery up to 90+%. But in the vertebral fistula, the chance of preservation of the vertebral artery itself is approximately 60-65%. While in some publications, this is the Thai group, also they published that paraneurasal sacrifice is up to 85%. The important is that not only sacrifice, but we need to close completely the fistulas. In young child, another way you see that ipsilateral vertebral didn't give any supply to the posterior circulation. How come? Fistula is on the right side, you have something effect to here, and you must realize that before the treatment you should be able to immediately think that what supply the posterior circulation. So in this situation, even they go right to contralateral side to be able to treat the patient, but we all know that it is called reverse basilar artery flow, that if you inject anterior circulation, for sure all the PCOM or connection, other connection, you run down to supply all the posterior circulation, and it is seen there that the reverse flow of the basilar artery via the large communicating artery is always there, and if you were able to close the fistula, the vertebral artery may come back and help to supply the posterior circulation. A little lower down, the fistula is seen there, compress the cord and nerve root. You see this area nicely, and I highly recommend you to draw the line of the segmental artery. If you put in the same level of the right and left, you will actually know that the embolic material is to put to close up there, and this is how it helps you to see that the fistula is closed and the remnant of the distal arteries to be able to help supply the posterior circulation. This is nice example of insult that he showed this right CC segment arteriovenous fistula between vertebral artery to the vertebral veins and further to the epidural venous plexus, and was able to look at this carefully with the contralateral injection and all the cervical artery injection. This is the arterial protocol that you need to do in this type of disease. And he was able to put nicely the coils packing to close up the fistulas, and this is control angiogram. Lower down, you are having this a little bit lower down with myelopathy. The MRI was already enough to show big venous pouch that compressed, and if you were able to treat nicely, this is before and after treatment, you were able to collapse this vascular pouch to the tiny little flat thrombose structure. Lower down, this girl is having mild cardiac congestive heart failure, and you see that the shunt, the fistula is much lower down there, and you will be able to see even this contralateral filling down, and you were able to use the coils, see some variation at the C1, C2 segment, and this is how we treat. So mix a little bit with another tool, which is traumatic and vascular pathology, including this metameric, paraspinal pouch and intradural vessel is seen nicely there. And you see only the skin subcutaneous muscle and the intradural vessel with the pouch. Try to combine everything into one disease, and to try to combine that, come to your mind that it's metameric lesions, that one can be the fistula with the venous pouch and another one can be the malformation that associate in the same metameric disease, and this is the skin of the lesion. When you have trauma, this is after the surgery, and you have the bruit, and this is the fistula at the C6 space. A little chronic fistula, you can see all of these, possibility of collateral to supply the sucking fistula, including the flow from anterior circulation, filling down to supply this. Where in this case, the pila or at the end of this injection supplying the lesion, if you were able to preserve, we were able to put 2 balloons there, and we were able to preserve this left vertebral, and finally the left vertebral was in help to supply also the posterior circulation later on. I was having 2 slides of new devices. As you know, we don't have any more detachable balloons in the market. So people, if you cannot finish with the course, people try to put new devices. For example, this publication of web, I would say that I never use by myself. I just say that sure, it is same as the flow diverter, but make sure that you understand that usually in the fistulous type like this, you never use one flow diverter, 2 or 3 or 4. So think about using many flow diverters before you can have a result of that. And the publication is 1 or 2 cases, not even the case series of using new devices. So just listen and be careful to follow up all of these results. Last group is what I told you about these plastic vessels. If you have a clinical for sure of this neurofibromatosis, and you have a lot of deformities of the spine, a lot of deformity in the brain, the base skull, and you see this pouch, which is related to the fistula, opening of the fistula with a large pouch. And if you were able to treat, just be careful, because you are now dealing with pathological vessels. The possibility of having the same strong layers of artery cannot be expected. And most of our cases, we treat, I think 3-4 cases of NF with this, we cannot preserve the vertebral artery. We can treat completely the fistulas. This is in a group of Sirintara. They have this gigantic. Look at the arterial access. It's probably not easy either way to go transarterial into these super kinky, tortuous vessels. Try to think about even go via the internal carotid, come down the area to close up. Look it carefully. There is some narrowing part. Make sure that you can close up the fistulas. The team was making, I think they make a very nice result after that. Probably last case, the NF with, they excise the mass. Probably they believe that it's a neurofibroma, and now we have something to replace the neurofibroma, which is now this pouch. So again, we need to go up and down by the contralateral side to check whether we were able, and this is from ipsilateral, this is from contralateral. Now you know all the way of the upper and lower aspect to be able. So I can tell you that to put a lot of things expecting to preserve. Finally, we were able to close up the fistula, but most of the time we were not able to keep the vertebral artery open. Next slide, to be careful from Carl. One, the collaterals help you to see exactly the fistula. And remember, the second one, after treatment, you need to go back and check if there is something left to be treated to complete via all the collaterals. Okay, in some situation you will see the thrombosis, but if it persists after 10 to 20 minutes waiting, you need to try to find a way to finish the job. So in conclusion, we are talking about the group of Parachordal Avf, and the treatment is for all symptomatic cases, and we love to do the curative treatment. We are doing with the arteriovenous big fistulas, big artery and big veins. So in the vascular type of treatment, you can use whatever embolic material you have in your countries. And I told you that probably the importance of completely close up the fistula, especially in this group of disease, is very important. Somatic level, in vertebral level, you may have not very high chance to preserve the parent artery, while in the cranial level, you can have a big chance of preservation of the parent artery. So thank you for your attention.